Hello, and thank you for joining the Rosewood Institute's clinical webinar lecture series. Today I'm happy to announce we'll be presenting the one-stop shop, applying the 12-step model to eating disorders, presented by Shaul, Austin, licensed professional counselor. My name is Libby Neal. I'm the Executive Clinical Director of Education and Training for the Rosewood Institute, and I will have a question and answer at the end of this session, and you'll also see my contact information on the last slide. Let me know if you want a copy of the slides or you have any questions, and I'm more than happy to follow up with you via email or phone. And on that note, I'm going to pass it to Shaul Austin.
Thanks, Libby, for that introduction. I thank all of you who signed up and logged on to this webinar. I know most of you have busy schedules, and I'm really happy and excited that you're able to be part of this. My hope is in this presentation that you'll find it interesting, enlightening, thoughtful, and it makes you think. It stimulates maybe some new strategies to treat those suffering from addictions and eating disorders. So to begin, what evidence supports in traditional chemical dependency treatment, usually in people who have both an eating disorder and a substance dependence diagnosis, usually assessment for eating disorder is poor or not done at all. And many times what happens when the patient will stop their chemical dependent behavior of drugs and alcohol, what will happen is their eating disorder behaviors will increase, such as purging or binging. And many times we will get a call saying, you know, we're treating their substance abuse, but this eating disorder stuff we can't deal with. And on the other hand, with traditional eating disorder treatment, many times if there's a comorbid chemical dependency problem, it's not necessarily the priority. Maybe they haven't, had a problem with it lately, and the eating disorder has been the focus. So many times that gets overlooked, and as they go from inpatient to a lower level of care, they may relapse on their or on their chemical dependency behavior. And also, many patients come and they just have an eating disorder diagnosis. And a lot of times what happens is the steps might not even be mentioned, or the 12-step philosophy. So as a clinician that treats both of these disorders concurrently, I'm always looking for how best to treat the people we serve. So raise the question, what's missing? Are we providing everything that we can for recovery for eating disorder clients? We provide compassionate care. We provide the latest in treatment modalities. But do we prepare them for life after treatment? How do we support our clients when we're not available? We may have them for 30 days or 45 or maybe even 60 days or longer. But recovery, especially early recovery, is tenuous at best. What do they do afterwards? How do we support them? When do our clients practice what we teach them during the structured therapy hours? Treatment as a community. We practice DBT, how to express feelings, grounding skills, meal plan, etc. But many times, do they know how to do that, post-treatment, or do they have a community to do that? Could it be that our clients relapse due to our overestimation of their stability during structured programming? Many people do very well with structure, and that's exactly what they need, and they fall apart at maybe the IOP level of care where they have 20 hours of the day that they're accountable for, and then they go to a group for 4 hours an evening. And so are we preparing that for what can happen or the pitfalls that what might happen when they leave that inpatient level of care? Could it be that the eating disorder replaces a person's value system? An eating disorder is really an adaptive function, and many people will say their values are they define that by their eating disorder. So that's a question one can ask. Are there really separate treatment options? Is this one camp over here? We have the bio-psychosocial model, and we have this 12-step model, and we have eating disorder and chemical dependency. Well, what I think is that, or what I tend to believe is that they complement. That the 12-step philosophy can complement eating disorder treatment, complement the structure, the psychoeducational skills, the experiential groups, and the dietary part of it. Why the 12 steps for eating disorders? Well, isolation is, it's a big part of relapse. People go from community, as I've mentioned before, and they go back home. And when they go back home, and they're in isolation, they're right at the same place where their eating disorder flourished. The 12 steps can provide community to practice the skills learned in treatment. A sponsor is invaluable. That is a mentor, a guide, someone who has been through it, someone who can show them what early recovery is like. And they're not going to be able to pull the wool over the eyes of a sponsor. A sponsor can be there for accountability, but also as support. Self-help versus treatment. Treatment is professional. When they leave treatment, the professional doesn't necessarily stop, but it's definitely not as intensive. And with self-help, it's really a way that they learn life skills, that they're with other people and they can learn those life skills. The stories. One of the healing things is, as a therapist and done primary groups, is the ability to tell their stories, that they don't feel like such an outcast, that they don't feel so disgusted with themselves, and knowing the difference. There are some differences, obviously, with chemical dependency clients and eating disorder clients, but with an eating disorder, they are unmerciful in the self-destruction of beating themselves up. So in telling the story, whether it be through a life story or a first step, yes, that's great in treatment, but they have the opportunity to share what's going on in the first year and in the second year, where they can share with somebody, whether it be the sponsor or whether it be in their meetings. Values taught through others trying to do the next right thing. Part of the 12-step philosophy is teaching, is replacing those values. If the eating disorder gave someone an identity, and that is their value, or it gives them self-esteem, or it gives them nurturance, one of those adaptive features of it, and you take that away, then they need to replace it with something else. And they can find a new purpose in living, a new purpose in life. And then the last one, normalizing urges, traumas, and family secrets. Yes, people come in with their secrets. I remember telling people, I said, when you come into treatment, get rid of those secrets, but don't create any new ones. Well, of course they do. And when they leave treatment, they can also be able to talk with, as I said, a sponsor or with meetings and discuss things that are going on. Just because one leaves treatment doesn't mean that traumas don't occur or family secrets don't happen. Eating disorders and addiction. Brewerton found similarities between sugar withdrawal and bulimics as with addicts detoxing from substances. And that sort of raises the question, well, is an eating disorder addiction? Well, we see similarities, but the jury's still out on that one. But I do know this is a 12-step model, supports treating both. You can treat both simultaneously. And that's really important. 60% of the people with an eating disorder report abusing or being dependent on drugs and alcohol. And anecdotally, from my experience, that is correct, and it may even be higher. Killeen discovered that when the addiction is taken away during treatment, an eating disorder will rapidly increase to the point of needing eating disorder treatment. Seen that also being true. Treating the addiction and the eating disorder together reduces treatment costs and increases recovery rates. Absolutely. Fractured care, we live a lot of times where there's fractured care. Well, as a physician, they will treat one part of the body, and the patient is left to go and find out which doctor they have to go to get this fixed. And in some ways in mental health, we've had this. The person comes in and they're in the mental health system or they're in the Office of Addictive Disorders, and they go back and forth. And it's how the clinician sees it is how they get treated. And when you treat it all together, there's better care, there's better communication, there's better treatment planning, and therefore better outcomes. Trauma history reported is nearly 60% of those with addictions and eating disorders. I would say anecdotally that's higher. I usually tell people, I say, the primary driving force with this started way before the food. It started with the abandonment and with the trauma. So the goal is not to substitute a substance for an eating disorder behavior or vice versa. It's to teach self-help skills in combination with traditional eating disorder recovery skills. So what is this 12-step model of recovery that you hear about? Well, it's a set of guiding principles that outline a course of action for recovery from addictions and other disorders. It's admitting that one cannot control one's addiction or compulsion. I think that is really a key part, is whether it be a substance abuse or an eating disorder, there is an entrenched denial system. And it is difficult to break. And a clever therapist can do that, but the first step really can help somebody with that is to find out what is are they powerless over? You know, what am I trying to control that's really uncontrollable? Recognizing that a power greater than themselves can give them strength. The eating disorder has all power. For many coming in is this is what will get me through. This is how I define myself. When I'm feeling terrible, I'll feel better, even if it's a little while. For a moment, I feel good. And this is a somewhat of a controversial thing in the steps because a lot of people think they have to find God. And many of the people are running away from that or have had bad experiences or maybe not an experience at all. So one of the things I try to do is even in the first group it says, you have people in this group who are getting better. Can you utilize what's going on in the group as something greater than you? That these people together can give you some hope and give you strength. And a lot of times it starts with that. There's a part of examining past errors with the help of a sponsor. That's a real important part. You know, the first 3 steps have to do with I can't do it on my own. There's some hope that I can with the help of others. And then the third step is really I think I'll be willing to allow that to happen as opposed to being willful and doing my own thing. Well, at that point, the person is saying, you know something, I've done some damage to myself, and I've done damage to loved ones and to others. And a big part of this is examining what those past errors are, making a list of maybe fears or resentments. And you do this with the help of a sponsor who has done it. And you write it down, and that's the 4th step. And then you confess it, in essence. You tell somebody else. The step reads, admitted to God, to ourselves, and to another human being the exact nature of our wrongs. And there's a real healing part to that, is sort of to raise one's self-worth and to be able to clean one's, clean one's side of the street. And then they'll have a list of making amends, the people. What I tell them is to make amends to yourself first. Would you treat anybody the way that you treat yourself? And in making those amends, you do it to others. And that's not really an apology. It's an amend is something that's a little bit more. It's really a restitution step where you say, you know something, what I did was not okay, and I'm going to make an amend. An example would be, hey, self, what I did to me was not okay. And the way I'm going to make an amend to self is I'm going to go to my meetings. I'm going to follow that meal plan. It's learning to live a new life with a new code of behavior. If the life they know to live for years, 10, 15, 20 years, is to basically live with the specter of an eating disorder, it's really calling the shots. Many times they have no clue what to do. And so early people in recovery and going to those groups will help them. You find a new purpose, a new way of living. Instead of being self-centered and selfish, there's the part of helping others and looking to others rather than yourself. And then helping others that suffer from the same addiction. The 12th step says, having had a spiritual awakening as a result of the steps, we carried the message to others and practiced the principles in all our affairs. So what this really is I tell people, be a sponge. That first year, learn as what you can, but then squeeze the sponge, help others. And part of that is really an insurance that you'll be okay yourself. And, if someone's in a really bad place, they can call somebody up and let them know. But at the same time, someone may call them and they'll find a new purpose. So more specifically on the steps, it's, admission of denial. You get honest with the dishonesty. There's hope. That second step is hope. As I've mentioned before, surrender. It's being able to say, okay, I quit. I give up my right to control this. It's cleaning house. It's looking at that wreckage of the past and looking at some of the stuff that the person's not really proud about. Of course, making amends, making restitution, first and foremost to oneself. Personal responsibility. People are responsible to the eating disorder, but maybe not so much to themselves. So it's learning to, the old adage is when someone starts their eating disorder or addiction, let's say it starts at 13 and now they're 27 getting help. Well, they're probably 13 emotionally when they're that first year on how to deal with stuff. It reduces shame and isolation, especially, the isolation piece. When someone's in isolation, the shame is just, all over the place. It improves self-worth. They give a purpose of living. It increases a spiritual connectedness. I think this is really important because many use the eating disorder or the substance as a way to connect spiritually. It's to deal with that pain. It's a pathological way to connect, granted, but it works, and that's why it's so addictive. It's why it's hard to stop. So part of it is learning that connectedness, and that's really done with the 11th step too, is with prayer, meditation, quiet time, and the things we teach in treatment. They can continue to do that in meetings and in their time that they use. A design for living through healthy values, and the design for living part is exactly, I believe, what a 12-step program is. It gives a healthy design for living. We can do the treatment part. We can do professional treatment and good treatment. But if they can't carry those treatment gains out to the real world and they don't have a plan, okay, not just a meal plan. Meal plan is important, probably the most important, but the design for living, how to live on life's terms, will keep them in recovery. And then the traditions, and the traditions were there to really for the group, so the group would survive. You know, they used to say, well, A will destroy. If it's going to be destroyed, it's going to destroy within. So it talks about some other principles such as anonymity, principles of rotating leadership, principles of service work, of helping others. And this is really, these things can be carried. We teach the traditions in one of the didactic groups that we do. And I think it's a real important thing because those not only are corporate traditions for a group, but they also can be used individually. Including the 12-step model with your eating disorder program. Well, one of the things to look at is moderation. Obviously, with substance abuse, there's abstinence. So you really have to tailor it. Abstinence is part of the problem for lots. But you can talk about abstinence with purge behavior, with laxative abuse, with those types of things, you know. So we look at a healthy meal plan. We look at what is healthy exercise. You've been in dysfunctional exercise. Now it's time of getting a new relationship with this. You know, am I doing this behavior because I have to, or is it because there's joy in eating? And that's part of capturing it and teaching the balance of moderation. In treatment, the first and second step may be all that you get to, but that's pretty big. That first step of reducing the denial and getting them to realize how bad it is, and that second step of giving them hope, well, that's a good start. And what I always do is encourage continued attendance. If they go down to our partial level of care, that they go to meetings. That's part of it. The outpatient level, even at IOP, they attend groups in community. It's a big part of filling up that time. And in inpatient, there's peer-led groups. You know, we'll have people come in from the outside. There's hospital and institution meetings, and there's people who can come in from the outside, and they can do a CODA meeting. They can do an NA or AA, ABA or ACOA. The hard part, though, is there's so many more substance abuse meetings and 12-step meetings than there are for eating disorder. But I'm real big in saying, you know, you're the generation to do this. Yes, it's like AA in the 40s. It's hard to get to a meeting, but this is the generation that can then help future generations to make it easy. And I'll always ask them to attend a few 12-step groups before dropping out. You know, if you don't like a meeting, find another one. Many times they don't identify, but I said just stay, and you might hear your story, or someone might give you a gem that you're going to hold on to. But you go to a lot of different groups. I encourage many times for women to find a strong women's group to go to, and that's where you're going to find a female sponsor. Traditions as a guide for group attendance. The traditions, as I mentioned before, will help people. Many people come in with no values or behaviors that are inappropriate. But what will happen is these traditions that are talked about in the meetings will give them a guideline for how to act in a group. And these can be carried over into business meetings. They can be carried over into their family. These are valued traditions that have worked over thousands of years that they teach at these groups. And then the importance of getting a sponsor. I've mentioned that. It's a guide. It's someone who is a mentor. It's someone who you can call. You're not going to be able to get the psychiatrist at any time, or the dietitian or your therapist. So especially in early recovery, those who get a sponsor have someone, and it's someone who knows. I would encourage as many years as possible, but you know, with at least a couple of years that they've been through the tough times, and they've worked those steps, because what a sponsor does is help people go through the steps. And it will also teach clients to start a local group for eating disorders. Many of our patients our clients go to regions where there's no meetings and they don't have an alcohol problem. And there's maybe not that many CODA groups. But what they can do, especially with social networking, is they can say, hey, I'm starting a group. They can go to the website of whatever the organization is and say, I'd like to start a group in this area. And maybe only 2 show up. But at least for that night, that evening, 7 o'clock on a Tuesday, they're showing up. So in conclusion, the 12 steps are not a replacement for eating disorder treatment. That would include a dietitian, psychoeducational groups, experiential learning, or medical or psychiatric team. But it will enhance the recovery. It will enhance it. It is available when therapists are not. It provides community to learn in and practice what is taught in treatment when treatment is over for years down the road. And it teaches very important values and spirituality. I really appreciate being able to present this information. I'm going to hand it back to Libby and see if there's any questions that may be answered.
Great, thank you, Shaul. It was very informative, and I do have some questions for you. And so let's see how many of these we can get through in the time that we have left. And I'm just going to start off with one that relates to the eating disorder, which is, how do you see the 12-step model being helpful for folks during their mealtime?
Well, I think the biggest one would maybe be the 3rd step, where it's surrender. They might be doing fine and waking up in the morning, and they sit down and they see breakfast and they go, oh no, how am I going to do this? And they're back at pre-contemplation where they give you the yes buts. But what they can do is use that step and say, okay, I'm willing to try this. I'm willing to eat 100% and go through there. So I think you can use it with that.
Great, thank you. I wonder if you have any sayings that you use in the 12-step model that have become, you hear yourself saying over and over to folks, especially in their first few weeks of coming into an inpatient setting, which can be quite overwhelming for somebody and even quite discouraging for them.
Well, I think the main one that I use a lot is 1 day at a time. And I modified that a little bit, and sometimes I'll say it's 1 hour at a time or 1 minute at a time. Another one is stay in the now. That's one, is try to stay focused right here on the now. There's one called HALT that's used in, and I think it's applicable to eating disorders. HALT stands for hungry, angry, lonely, tired. And if you get too hungry, you need to eat. If you're angry, you need to express that. If you're lonely, call somebody. If you're tired, you need rest. And if you have 2 or more of those, you can have all sorts of problems and maybe be susceptible to relapse. There's another one that's kind of interesting, and it's kind of humorous, but it basically says, in essence, nothing's a big deal. It says, don't pole vault over rat poop, so to speak, because not everything's a big deal. And to help them focus and say, this is what's important right now, and what you need to do is attend your meeting or to follow your meal plan or to call somebody.
Great, thank you. And you mentioned in an earlier slide something about the importance of making amends as part of the steps. And I wonder if you can talk a little bit about the difference between, or the similarities between, an amends and an apology.
Well, an apology is, basically is, okay, I'm sorry. And many times the person says it to themselves, or they say it to family members. And family members, quite frankly, are tired of apologies. What they're looking for is action. So one of the things to look at is to make an amend is really a behavior. That part is a behavior. So what you're saying is, I did something wrong, and this is what I'm going to do about it. So what I'm going to do about it is I'm going to go to a meeting, and I'm going to call my sponsor. I'm going to follow my meal plan.
Okay, great. And I wonder if you can speak a little bit about the spiritual component of the 12-step model and how a person can find what they need in working the steps in relation to the eating disorder.
The spiritual component. Well, in some ways it's spiritual kindergarten. And one of the spiritual component is it's getting out of ego. The part of the steps really has to do with giving up, as I said, surrendering. It's part of looking inward and also looking outward. So part of it is those steps that look at behaviors and so forth. And the other part is saying, hey, I can't do it on my own. I need help. And a big part of the steps is not only being with people in community, but also learning a quiet time, a time that you can be alone and get centered and so forth.
Great, thank you. And if a therapist or a mental health practitioner wants to get started in working with the 12-step model in their private practice or in a outpatient or inpatient setting, what do you suggest that they do to become familiar with the 12-step model themselves?
Well, the first part I would say is look on the internet, because there's so many resources there. And each one of those groups, there's probably 50 groups in the last 70 years for 12-step various groups, and which has helped millions of people all over the world. So it's accessible, and they all have web pages. And then the other one is I would look on your treatment team if anybody's in recovery. And many times their story and their experience can work, wonders with that. They can get that information.
Great, that's very helpful. Can you say a little bit about what the tradition is of 12-step groups being used in a hospital or inpatient setting?
Well, in the beginning, it's interesting. In the very beginning of AA, before there was treatment centers, the 12-step was two alcoholics went to a hospital and visited another suffering alcoholic. And what they said was, they told them their story. And in essence, when someone was new in recovery, maybe only 30 or 60 days, and they got a sponsor, the sponsor would say, guess what we're going to do? We're going to do some 12-step work. And they would go to a hospital. Or they would go to a prison. And they would, with the clearance and so forth. And they would tell the story and start a meeting. And that's really how it started, with the whole idea of in order to stay sober, in order to do it, you have to help others.
Great, that's very helpful. And I wonder if you can say a little bit about how you integrate the 12-step model into your work as a therapist. Do you let the client know that that's part of your belief system? Do you just start integrating it in? And if you just start integrating it in, how do you do it, Shaul?
Well, I think it doesn't come right off the bat. And so when someone first comes in, I'm always looking at relationship. Because they're coming into treatment, they're scared, they are not sure what's going on, or maybe they're feeling guilty because they've been in treatment several times before. So I really want to know about them and let them know that it's okay. At some point in that relationship, one is it's built into our curriculum, but at some point in the relationship, I may ask them, have you experienced in meetings? Have you gone? Have you tried this? And then I might even ask them, do you have any opinions about it? And sometimes it's, well, it's a religion, I don't want to do this, or it's this or it's that. So I just try to ask questions. Now, if I do self-disclose, it's always for the benefit of the patient. And that's part of the ethical part of being a licensed counselor. And if it is needed and they ask me a question, I will answer that truthfully and help them, if they have more questions, to help them out.
Great, that's very, very helpful in getting started. I wonder if you can say a little bit about what your experience has been for folks with eating disorders who have fallen into relapse. How do you use, or how do you teach them to use the 12-step model when they're at that point?
Well, the first thing is to get back to a meeting. One of the things, and let them know that that's important, because one of the things at meetings is they don't shoot their wounded. When someone is struggling, they say, glad you're back. So it reduces the shame right away. It goes from the isolation of that relapse to, okay, these people understand and they get it. So that's the key. I say, don't isolate, get with people, go to a meeting. And then using step one and looking at the first part of step one. It's interesting, the only part of the steps that really talk about eating disorders or addictions or the problem is the first part of the first step. But that can tell a lot. So I will use that first step and say, okay, where did you take your power back? Where did you find a way that you needed to do something? And usually it starts with meal plan or exercise or something like that.
Great, very helpful. And As the old saying goes, Shaul, there is something called a 13th step. Can you say what that is and why that's a cautionary tale?
Absolutely, especially with population we treat with their history of trauma and so forth. Not everybody in 12-step groups are healthy. And one of the reasons I talked about women's meetings is because many times you have mixed meetings and men will see women and they will use that as a way to hook up with a relationship. And well, I can't think of anything that is more problematic to the individual new in treatment looking for help, anything more damaging. But that does go on, and I tell people to stick with the winners, that you don't put up with that. That's really another addiction showing its ugly side. The person may have stopped their eating disorder, they may have stopped their substance abuse, but they're still struggling with sex and love addiction. And so I do mention it and say, listen, stick with the winners.
Very helpful. Complicated treatment process. And we are at the end of our time. And Shaul, I just want to thank you for coming in to do this wonderful presentation on how to use the 12-step model for folks with eating disorders. And the slide that you see on the screen has my name on it and my email contact. So please do let me know if there's anything I can do for you or if you would like a copy of our slides. And we'll see you at next month's webinar. Thank you.